So improper handling of drain, as I mentioned, we can cause surgical site infection. So we'll talk about that in a minute here. Okay. Typical drains I use, if it's the back of the neck, back of the back, or back of the low back, that's going to be a hemovac. And if it's the front of the neck, I use a JP, a Jackson Pratt. That's the little grenade-looking thing. Okay. The reason being is that these hemovacs can create a lot of pressure, suction pressure, and I find it to be too much, in my opinion, for the anterior neck. Again, this is a little bit of a world according to Jason. This doesn't necessarily mean this is right or wrong. It's just the way I do things. Okay. So unless the order state otherwise, maintain these drains to suction. Obviously, never connect these to wall suction. If you find that things not working, please don't ever stick it on the wall suction. Okay. Occasionally, we will have a problem from surgery called a spinal fluid leak. You may have seen a patient before that's got a spinal fluid leak. We get new precautions when that happens. And if we have a drain in there and they have a spinal fluid leak, we don't want to put suction on that because that suction can then cause a problem where it actually opens up the repair that I've created. So I will tell you, obviously, if that's the scenario. Okay, you'll see an order that says do not place the suction. I usually put a sticker on the drain, do not compress, something along those lines. Okay. It's important to drain the hemovac or the JP when they arrive on the floor and measure that in the electronic record. And then every 8 hours following that, okay? And the reason why it's important to catch it every 8 hours is that my parameters for when it's okay to pull the drain are based on what the output is for 8 hours. And so if we don't get the drain recorded for 8 hours, if it's 10 or 12, then I start having problems trying to figure out where they are. I can watch trends a little bit closer for doing every 8, okay? Again, have that suture removal kit at bedside, as well as betadine gauze and tape. And the betadine gauze and tape in this kit are, again, it's potentially for emergency, but it's going to be always for when we do take it out, because the patients, by and large, never go home with the drain in, okay? So when do we call the doc? Well, call if the drain output is more than 100 cc's an hour, or more than 300 cc's over 8 hours for the thoracic and lumbar spine. And in the cervical spine, if it's more than 50 cc's per hour or 150 cc's by 8 hours. You say, well, how do I know it's more than 100 cc's an hour if you want me to measure it every 8 hours? Well, if you're going and doing your checks and you're looking at the drain and it looks like it's full and you're at hour 2, then by all means, don't wait to 8 hours to empty it and measure it. Go ahead and drain it and find out what that is and record that. And then open it up and then recompress it and then come back in another hour. And if it's filling up again, measure what that is. And if it's over these parameters, and give me a holler, okay? If the drain pulls out, again, don't try to put it back in. You can take a piece of gauze, 4x4 or 2x2, soak it with some betadine, okay? If we don't have betadine in the bottles on the floor, I'm pretty sure we do because I believe I saw it up there. You can use the betadine swab sticks, but I like the betadine soaked better. And you put that over the drain site and put some tape, okay? Again, if the drain pulls out unexpectedly, like say day 0, night 0, or day 1 and we were having it in, there's no need to call me to tell me, hey, it pulled out, unless you were getting ready to call me anyway because you found that the output was pretty high and it's been going pretty high, then give me a call. Okay, not much usually we're going to do. We're not going to go I'm not going to take them back to the operator and put a drain in, but this kind of allows us to be a little more vigilant about watching to make sure they don't develop these symptoms of compression. So what's our drain criteria for pulling the drain? If there's less than 10 cc's of drainage in the anterior cervical in 8 hours, 20 cc's for posterior cervical, and 30 cc's per 8 hours in the posterior thoracic and lumbar. Now these are general rules of thumb, and have I pulled them with more than that? Sure. It has to be taken in the kind of the grand scheme of things, but this is the general criteria for pulling them. Okay. So when we remove the drain, first thing you do is you take it off suction. Okay. You take the suction out if it's the hemovac or the JP. Next thing you do is you have your 4x4 gauze soaked in betadine. You get that suture removal kit and you cut the suture that's holding it in. You pull that suture out and you pull the drain out. Okay, pretty simple. Most patients bothers them very little, if at all. A lot of times patients don't even realize you pulled it out. Okay. Sometimes as you pull that out, especially in the lumbar spine, because they're a little bit bigger drains, you'll start seeing this blood clot. It looks like this bloody kind of snot-looking thing. It's disgusting. Okay, it comes out. It's starting to come out of the back. That's the blood clot, as you might gather. It's been sitting in there a little while, and the blood's clotting. That's what blood does, okay? The tendency is that clot wants to fall back in the hole. You don't want to let that happen. So as it's coming out, that's why you have your gauze ready. If you see one of those things, you just grab it and pull it out with the drain, okay? And try not to stifle your gag if you think that's gross, and don't let the patient know and freak them out. But that's pretty normal if that happens, okay? Then if that happened, that means you get a new piece of gauze and put some Betadine on it, put it over that hole, and put some tape. That's all there is to it. It's nothing fancy. It's not rocket science. If you have any questions about it the first time, you want me to be there for it, that's not a problem at all. So ambulation. So most of the surgeries I do are some form of minimal invasive techniques. The goal of these things is to get people up, get people moving, and get people home. As you know, longer people are here in the hospital. That's when you start getting infections, bed sores, everything else. We want them out of the hospital so we don't get the complications, okay? So most patients of mine will go home within 2 days. Okay, vast majority, I would say probably 90% or more will be home within 2 days, okay? To help facilitate this, though, there's a lot of things that have to happen, okay? And you guys are kind of the key components of that, all right? We got to get people up and we got to get people moving. So if they had a morning surgery, a lot of times I want them out of bed that day, okay? If that even means just getting to a chair, that's okay. I've been talking with physical therapy. We're working with physical therapy. We're going to try to get people seen twice a day with physical therapy, okay? Physical therapy may ask for bedside commodes, things of that matter. We'll have discharge planning. Just let me know if we need help coordinating to get these things. We'll work with them and get things moving. Out of bed to the chair at a minimum of 2 times per day, okay? Again, day of surgery, they at the very minimum should be sitting up in the bed, dangling their legs over the edge of the bed, okay? The more they lay in bed, they're not deep breathing. If they're not deep breathing, the air's not moving. If the air's not moving, guess what? You're going to get pneumonia, okay? Or you get first what's called atelectasis, which basically means the lungs are not moving the air like they're supposed to, and then you get pneumonia, and that's when you get those fevers, okay? So the other thing we need to do is make sure that they have incentive spirometers, okay? And it's real important to use those 10 times an hour while they're awake. You don't need to wake them up, obviously, to do the incentive spirometer. But while they're awake, they should be using it. Again, if we're getting them up, getting them moving, there's nothing better to stimulate deep breathing than having a painful back and getting up and moving. It'll get you to move and take a deep breath, okay? So along those lines, pain control, all right? A lot of my patients will come up with PCAs. The PCAs, there's a funny thing to them. If they're not used in the correct way, they're not helpful for the patient, okay? PCAs are for breakthrough pain, okay? So for my patients, if they come up to the floor and have a PCA order, they're also always going to have oral pain medications ordered. Those oral pain medications, even if there's a PCA attached, need to be given to them, okay? Because I have no means of sending them home on a PCA. And I have no means of gauging whether I need to up their medications or lower their medications if their first line is hitting the button all the time, okay? I can't really translate that as easily to how much medication to give them. So if we start them, as soon as they start taking sips, as soon as they get to the floor with their pain pills, if we find that they're using the pump a lot, then I know I need to up my pain dose, okay? I can't emphasize this enough. We don't want to have this scenario where we say, oh, if their pain pump PCA setting is not working, then we give them the pain pill. That won't help them at all, okay? So and that way we find if our pain dose is right, we'll find them using the PCA less and less and less, and then we know we're on target, okay? It's also important, some patients don't want to take pills. They're afraid of becoming an addict. They're afraid of, they take this pain medicine that it's going to make them be too loopy, et cetera, et cetera. It's really important, especially in spine patients, to encourage them to take the pain medicine right away, okay? The reason for that is that if you get behind the 8 ball, so to speak, and allow yourself to get in severe back spasms, it's very difficult to play catch up. And no matter what kind of medications you give, once you go into severe spasm, they're going to be miserable for a while. And then we start playing this game of, oh, now we've given them too much, no, we haven't not enough, and so it's very difficult. And I try to educate my patients in the office ahead of time and let them know they need to take these medications, but your education building on that will be very helpful. Okay. So again, people who use the PCAs breakthrough only spend less time in the PCA, less time in the hospital, and less time overall in narcotics, okay? And that's including over in the long haul. So catheters, Foley catheters. If the patients come to the floor with a Foley catheter in, and with the minimal invasive techniques, most of the time I'm pulling that in the operating room, okay? So a lot of patients will not have a Foley when they come up to the floor. But if they do have a Foley when they come to the floor, leave that in generally until the next morning. After their AM morning physical therapy session, we can pull it. Now, if we get lucky enough and they get seen that day of surgery with physical therapy and they walk around, then you can pull it in the afternoon. Bless you. They will need assistance the first time they go to the toilet, but most of my patients, they can go to the bathroom that day. So as far as ambulation restrictions, I'm fixing them in theory with fusion or with decompression or whatever. There's not really any ambulation restrictions. In fact, they're encouraged to get up and move around. The only restriction I have on patients is to how much weight they can carry, and that's 10 pounds on average, okay? That's about a gallon of milk, okay? So as long as they're not picking up anything heavier than a gallon of milk, they're okay by me, okay? In terms of bathing instructions, I will give them bathing instructions when they go home. Generally, post-operative bathing instructions is they should not get the incision wet for 4 to 5 days after surgery, okay? I put a special skin glue on the incision that technically you can shower right away, but I don't trust it, and so I give them 4 to 5 days. So if they want to get clean between those 2 points in time, they either A, need to find a way to wrap saran wrap or plastic, people get very creative, and keep that incision dry, or they sponge bathe. Either way is fine with me. I don't really, it doesn't matter to me as long as they keep that incision dry for those 4 to 5 days. At that point, they're going to take that dressing down when they go home. So in most of the cases, we don't change the dressing on the incision in the hospital. Unless it's soaked through, then obviously we want to change it. They'll change it when they go home, and they're not supposed to bathe in a bathtub or a pool or soak it otherwise for 1 month after surgery, okay? And that's a bummer in the summertime. People can't go swimming. So again, Foley, if they come in the Foley, pull it out, follow your due to void protocol, okay? Braces. Most of my patients won't need braces. Exceptions to that would be a trauma, a multi-level fusion, multi-level cervical case. You might see one, but in general, we don't need braces. If we do, I'll put the order in. It'll usually be at what's called an Aspen collar for the cervical spine. Occasionally, we'll just do a soft collar, and then for the back, it's usually a TLSO, which stands for thoracolumbo-sacral orthosis. Okay. It's a bad trauma. They may have what's called a SOMI extension, which is basically a thing that comes up over their chin. And we will have to get the orthotist involved to get these things, okay? If it's a trauma patient, be sure to check the orders. But in general, if we have a brace, they can take its extra protection. It's not because they have to have it. And they can take it off to bathe. They can take it off to eat if it's a cervical collar. Take it off to go to the bathroom if it's a TLSO, okay? So that's a little bit less cumbersome for them. If it's a trauma patient, sometimes all bets are off with regard to that, and they may need that brace all the time. So just check the orders to see if it's a trauma patient, and I'll put something specifically that says, don't take brace off, okay? DVT prophylaxis, okay? So I use SCDs and TED hose in early ambulation. I don't give them any medications, okay, unless for some reason they've got a history of pulmonary embolus or something along those lines. Why don't I give medications? Well, what do blood clot medications do? They thin your blood, right? What we talk about, the complication I worry about most is a hematoma, right? So one of the complications from blood thinners is an epidural hematoma, which can cause either Cauda equina syndrome down low or paralysis if it's up high. We don't want that, okay? So I don't want that anyway. So I tend to not use any chemical prophylaxis, okay? Diet. Unless they're diabetic or cardiac or whatever, it's going to be advanced to general, okay? But it'll be advanced to general or diabetic or heart healthy or whatever it is that they need. Again, incentive spirometer, Q1 hour while awake at 10 times an hour ideally. Ice, the minimal invasive surgeries, what I like to do is some sort of ice pack. You can wrap it in a sheet or a towel or whatever and put that to the incision sites 20 minutes an hour while awake. Don't let them, if they're falling asleep because they're have a little bit of narcotic on board or they're still sleepy waking up, don't let them sleep with the ice packs on because they have no self-protective mechanism to say, hey, I'm getting frostbite, okay? And no ice directly on skin, as we all know. And that's it. You guys have any questions? There's a lot to get in an hour.
Well, I have a question.
Sure.
I don't deal a lot with the orthopedic doctors. Is there somebody on call 24 hours?
There's always an orthopedic doctor on call. Now, whoever's on call may have a lot of comfort with the spine, may have a little comfort with the spine, but thankfully, the day in, day out, the average things that you'll be calling about for your spine patients are going to be pain control issues, okay? And like I said, I generally like to adjust pain by adjusting the oral medications first, because ultimately that's what they're going to be going home on. The two medications that you'll see, oral medications that you'll see all my patients have are a muscle relaxant and a narcotic. Really, the muscle relaxant is the key component of the pain control. I like baclofen a lot. You'll see me ordering baclofen for the vast majority of my patients. People over the age of about 60 to 70 tend to get a little bit of almost like a sundowning with baclofen, so I usually will order Valium or Flexeril, something like that for those patients. But everybody else will do baclofen unless they have a reaction to it.
With that Cotta-Klina syndrome,
Mhm.
will there be any kind of like vital sign changes that?
If they're in a lot of pain, the blood pressure will go up and the pulse will go up, but that's apart from that, not usually. I appreciate.
When do you start?
When do I start?
Yeah.
Monday.
You start Monday.
Monday. I appreciate your all's attention.
Do you have surgery scheduled yet?
Not yet.
Not yet.
Not
okay.
yet.
So your office is at the Carolina? Or
Orthopedics, yeah. So I'll be at the Parker Road office on Mondays and Wednesdays, and then in Valdez on Fridays, and then up in Marion some Fridays coming up starting this fall. But all the spine surgery will happen here. All right.
All right, well, thank you.
Thank you.